Okay, good evening, everyone. My name is Nicole Milano, and I want to thank you all for joining us both in person and online for our first ever hybrid Heberden Society lecture with Dr. Muigai. Now, for online attendees, please note that closed captioning is currently enabled if you have the updated version of Zoom. You can find the option at the bottom of your screen to turn the captioning on or off during tonight's lecture. Now, we welcome participation from on-site and remote attendees in our question and answer session following today's talk. For our online attendees, you'll find a Q&A box at the bottom of your screen where you can enter a question, and we'll get to as many as possible following the lecture. Okay. Now, after tonight's lecture, we do have 2 additional Heberden Society talks this academic year. On March 2nd, Dr. Naomi Rogers will present on health activism and community control in American medicine in the 1960s and 1970s. Finally, join us on April 26th as Dr. Jaipreet Virdi highlights content from her award-winning book, Hearing Happiness, Deafness Cures in History. I will be sending out more information about these lectures following tonight's presentation, and if you're here in person, I will send around a sign-up sheet if you're not yet on our listserv. Now, for those who are interested in the history of the New York Presbyterian Weill Cornell Medical Center, I would invite you to conduct research in our very own medical center archives. The archives includes materials dating all the way back to 1771, including records from the lying-in hospital created by Alexander Hamilton's family physician. An early 20th century delivery room from our hospital can be seen here. Now, more than 14,000 photographs and documents from our collections are digitized and available for reference through the link seen here. I want to thank the Office of the Dean for continuing to support the Heberden Society and to the New York Academy of Medicine for co-sponsoring tonight's lecture. On that note, I would like to welcome Arlene Shaner, Special Collections Librarian from the New York Academy of Medicine, to say a few words.
I am so glad to be able to be here in person for Wangui Muigai's Heberden lecture, which we are co-sponsoring. NIAM has co-sponsored a Heberden lecture every year for more than a decade now. As NIAM begins its 176th year, we continue to tackle barriers that prevent everyone from living a healthy life by generating knowledge, changing systems, and engaging the public to ensure health for all. And for those of you who don't know, we started this year with a brand new president, Ann Kurth, who came to us from Yale University. She is a PhD epidemiologist, but she also is a certified nurse midwife, and she has a master's in public health. So this is the kind of talk that would really resonate with her. As I want to just switch to the next slide here. There we go. So as always, I want to remind everyone that our library is open to all for research visits, and we have lots of content to share through the monthly newsletter, our digital collections, events, and presentations that are easy to find on our website. And I'm now very happy to introduce Pauline Flaum-Dunayer, the Weill Cornell fourth-year medical student representative to the Heberden Society, who will introduce our speaker.
Good evening, everyone. It's so nice to see people in person. I haven't done that in a very long time. Thank you so much for joining us for our first Heberden Society lecture in the new year. Today, it is my distinct pleasure to introduce our speaker, Dr. Wangui Muigai. Dr. Muigai, a graduate of Harvard and Princeton universities, joins us from Brandeis University tonight. She is a historian of medicine and science. Her research examines how race, gender, and age have shaped experiences of birth and death, sickness, and health. These profound issues shape our history and our everyday life. Dr. Muigai's dedication to these subjects have been recognized by several awards, notably as an Andrew Carnegie Fellow in 2022 and a past Fellow of ACOG. Please join me in welcoming Dr. Muigai to Weill Cornell Medicine.
Thank you so much for that introduction. I'm going to be here for a while, so I'm going to take this off. It's an honor to present as part of the Heberden Society's lecture series, and I want to thank Weill Cornell Medicine the New York Academy of Medicine for organizing this event, as well as Nicole Milano and Arlene Shaner for their organizing efforts. And thank you all for taking the time to attend in person and virtually. Okay, I think my slide should be coming up shortly. So for my talk this evening, I want to offer a historical perspective on the issue of infant death in America. And it's a perspective that will center, rather than marginalize, the experiences of Black families and their communities. This, of course, is not just a historical issue, but one that continues to be a serious concern for medicine, for public health, and most of all, for the families who are impacted by these losses. So just this morning, the New York Times published an article on maternal deaths in St. Louis and the role of birth workers, especially Black doulas, working to ensure the survival of Black mothers and babies. So I want to introduce you to earlier generations of Black Americans who are engaged in this same struggle, who lived in the 19th and early 20th centuries, parents like Harriet and William and Mary, share their stories of losing or nearly losing a baby. We'll learn of the challenges they faced in trying to safeguard the health of their young children and how they, alongside a broad coalition of healthcare professionals, activists, concerned citizens, pursued different strategies to draw attention to these threats, overcome them in hopes that others might avoid a similar fate. But before we get there, I'll start with a story you might be more familiar with. And it's represented quite neatly in this graph from the CDC. When we look, we see a downward trend in infant mortality over the course of the 20th century. And the graph begins in 1915. This marked when the federal government first began collecting systematic data on births by using a new kind of document called the birth certificate. At the time, government officials had a better sense of the number of cars, the number of pigs and cattle in each state than the number of babies born. So officials at the US Census Office developed a vital record system and used posters like this to get families involved in registering each of the births that they had. And as officials began to document births and deaths in the country, they found that well over 10%, or 100 infants out of every 1,000, died in the first year of life. From then, the steady decline in death rates was brought on by advances in public health, such as milk pasteurization, the development of sewage systems, which reduced the prevalence of water and milk-borne diseases that disproportionately killed young. Medical advances also played an important role, including the invention, the growing use of the incubator, as well as the introduction of sulfa drugs in the 1930s to treat bacterial infections like meningitis. But here we see by the 1950s, right in the middle of the graph, there's a leveling off, even some upticks in the infant mortality rate that came about because of new factors, such as more premature infants being delivered successfully, but dying within the first few weeks of life. Now, this slowdown came to a shock as a nation that had witnessed such rapid progress in the prior decades and considered itself medically and scientifically superior, especially following the outcomes of the Second World War. Following the stagnation in the 1950s, the decline in infant mortality rates begins to pick up momentum in the 60s and the 70s. And this was aided by the creation of new government programs such as Medicaid that improved access to prenatal care, especially for America's poor, as well as the development of new specialties like neonatology and obstetric anesthesiology that focused on the health needs of newborns and birthing women. Now, today, the infant mortality rate in the US hovers closer to 6 deaths per 1,000. And this remarkable reduction over the course of the 20th century has been described as one of the most dramatic and far-reaching revolutions in medicine and public health. But as a historian of medicine, interested in the relationship between race and health, I was drawn to a different aspect of this story that seemed more troubling than triumphant. And that was the question of why this blue line, representing the death rates among Black infants, has been consistently higher than the orange line, representing white infant deaths, and why this roughly 2-to-1 gap between Black and white infant survival has persisted for over a century. As much as contemporary reports frame the higher death rates plaguing Black mothers and babies as an emerging crisis, this graph instead shows a much more disturbing reality we have to reckon with. And that is that these racial inequities have endured for a very long time. And behind each of these statistics, each of these numbers, is a baby that died. So to understand the individual experiences underlying these aggregate numbers, I had to look to different sources than the kinds of information that you find from the CDC. And this included finding and listening to narratives of loss, stories of parents, grandparents, caregivers describing their experiences of losing a baby and of the struggles they faced in caring for a child through the first fragile days and weeks of life. In combing through family letters, parent memoirs, oral histories, some of which include really truly heartbreaking accounts, these descriptions are filled with an emotional intensity that you often can't quite access in more clinical records. And these kind of archival sources also give us insight into the different individuals and institutions that Black families have relied on when faced with a health crisis, who they've called on to help see them through pregnancy, birth, sickness, and death. And that takes me to another important group of sources: medical journals, public health reports, documents that chronicle the challenges practitioners have faced in treating young patients, patients too young to express in words their symptoms and their discomfort. Also allows us to see how the leading causes of infant death have shifted over time. Compared to the 18th and 19th century, when infectious diseases were the feared causes of death, today we worry about things like preterm birth, babies born with low birth weight, or even the more baffling diagnosis of sudden infant death syndrome. Additionally, it's worth highlighting the important role of the Black press, how newspapers like the Chicago Defender and the New York Amsterdam News have played a key role disseminating health information and representing the varied opinions and efforts of ordinary, everyday individuals who otherwise don't leave behind vast personal records. So when we look across these historical records, the different perspectives and concerns they contain, we begin to see how the history of infant death in America is a story that touches on broad transformations in medicine and society, changes in how we give birth and how we die, changes in how we've come to view infants as vulnerable, in need of government protection, and with distinct health concerns. My exploration of this issue is part of a larger body of scholarship that examines the tangled histories of illness experiences, such as diabetes, sickle cell anemia, and tuberculosis, and how they've been framed as, quote, racial diseases, identified with specific racial and ethnic groups, similar to the way infant mortality is often and incorrectly treated as solely a Black problem. And at the same time, as scholars such as Alondra Nelson and the physician historian Vanessa Northington Gamble have shown, the creation of Black serving hospitals, nursing programs, and even radical campaigns like the sickle cell screening program run by the Black Panther Party in the 1970s are all part of a long tradition of Black communities organizing for healthcare in the face of institutional racism and government neglect. So to really understand the roots of these racial disparities, we have to look at the conditions and practices that were hundreds of years in the making. Dating back to the 18th and 19th centuries, the best estimates we have indicate that between 20 to 25% of all babies died before reaching their first birthday. That rate was much higher for Black babies, especially those born enslaved, for whom over a third died in the first year of life. That's a staggering reality that families had to contend with, that a child's death could come at any moment. Even if they didn't experience the death themselves, families probably knew someone who did, of women who went from giving birth to digging a grave. Now, what made infancy so perilous, such a perilous period of life? Infectious diseases, especially those that impacted the gastrointestinal system, were a major problem. And the number of deaths due to severe diarrheal diseases always spiked in the summer months as contaminated water supplies, milk spoiling in the heat under the summer heat, increased the spread of bacteria and viruses. But even symptoms that seemed mild could quickly turn deadly. For example, a baby develops a sore throat. Now, was that a sign of a common cold or the onset of something much more deadly like diphtheria, which was often referred to as the strangler because it caused severe breathing difficulties and held its most fatal grip on young children? Yet even as acute illnesses were responsible for a large share of infant deaths, Black babies faced additional risks to their survival that stemmed from the brutal conditions of enslavement, of violent treatment that mothers endured, including when they were pregnant. If we look to the archival traces that Black women left behind, we come face to face with how experiences of gendered violence, of racial oppression, brought them in close and constant proximity to losing their children. And one of the most vivid examples of this comes from Harriet Ann Jacobs. Jacobs was born a slave in North Carolina in 1813, and as a young woman, she made a daring escape from her owners that involved hiding in an attic for 7 years, an attic so cramped that she couldn't stand up straight. But from there, she was able to plan a risky journey for her freedom, where she eventually got to Boston, wrote and published her life story in 1861. And this is one of the most well-known slave narratives written by a Black woman. Harriet Jacobs was owned by Dr. James Norcom, who was a highly respected physician who trained under Dr. Benjamin Rush. He received his medical training at the University of Pennsylvania. And when Dr. Norcom opened his medical practice in North Carolina, he became known for his obstetrical skills. Many white families from different counties in the surrounding area called on him to assist them during a birth. But when Harriet Jacobs became pregnant, Dr. Norcom was the last person she wanted to attend to her. And that's because she had endured years of violent abuse from Dr. Norcom and his wife, Maria. Their vicious treatment of Jacobs intensified when she became pregnant. In her third trimester, she was critically ill and bedridden, but she adamantly refused to have Dr. Norcom attend to her because how could she trust the physician who threatened and tormented her, who enslaved her to, quote, do no harm or injustice, as the Hippocratic Oath dictated? She spoke to this tension when she wrote in her autobiography, "I could not have any doctor but my master, and I would not have him sent for." Jacobs then gives us a really powerful account of her birth experience when she writes that, "When my babe was born, they said it was premature. It weighed only 4 pounds, but God let it live. I heard the doctor say I could not survive till morning. My master did not fail to remind me that my child was an addition to his stock of slaves." So here's a baby born early, critical condition. Jacobs herself was plagued by sickness for over a year following the birth. As she made clear in her narrative, enslaved mothers not only had to endure the painful and terrifying complications that could occur before, during, and after childbirth. If they interacted with white doctors, these were coerced and traumatizing encounters, which physicians like Norcom making it quite clear his financial interests and how he's viewing Black infant survival through a calculating economic lens. Both mother and baby survive, but this proximity to death, this intense fear that Harriet describes, the fraught nature of the doctor-patient relationship that she sketches out, really gives us a window into some of the struggles that Black mothers faced in protecting the health and survival of their children. And these are challenges that will endure through the end of slavery, with the rise of Jim Crow in the 1870s, a long period in which states and local communities passed laws enforcing racial segregation and denying Black Americans their full rights as citizens by restricting their movements, opportunities, and access to public goods like education. Racism was deeply entrenched and legalized segregation deeply entrenched across the country, impacting all aspects of life, including the access Black Americans had to receive and offer healthcare. Indeed, there were few opportunities for Black physicians and nurses to train, to specialize, and many white physicians refused to treat Black patients. Dr. Haley Tanner Dillon Johnson, who was one of the first Black women physicians to practice in Alabama, wrote about how white doctors were known to charge Black families for each mile they had to travel to reach patients, and that they demanded to be paid in cash and upfront before they did anything. Now, for poor Black families, many of whom worked as field sharecroppers, they worked the land, they had very little access to cash. Calling on a doctor would not have been an option. They relied on midwives, they relied on other lay healers and nurses in their area. In her memoir detailing her decades of caring for mothers and newborns in rural Alabama, the midwife Oni Lee Logan described that in the areas where she practiced, doctors were simply not an accessible or reliable option. She said, when you call on a doctor, even if you call one today, he might come tomorrow. He might come tomorrow. It was the midwife or nothing. So what options did Black mothers and babies have for getting hospital care, let's say, instead of maybe relying on an individual practitioner, if that's what they desired? As with all other facilities and accommodations under Jim Crow, separate hospitals existed for each race. Government officials didn't allocate the same amount of funding to Black communities that they did to white, so many Black hospitals were smaller, they were less equipped. And the few hospitals that did admit Black patients gave them horrible accommodations, placing them in areas like a damp basement or near a boiler room. Regardless of whether you were sick with tuberculosis or whether you were a woman in the early stages of labor, Black patients were placed in the same area, so irrespective of their medical needs or the contagious nature of their diseases. And this, of course, meant that when in hospital settings, Black mothers and babies were more vulnerable to preventable complications, to humiliating treatment, to risky interventions that could result in premature death. One 1937 study published in the American Journal of Public Health described the number of women who died from pregnancy-related causes as excessive. The health officer conducted a 5-year study of all maternal deaths in Jefferson County, Alabama, and found that physicians' errors were 50% more frequent in Black obstetrical cases. This is what Black mothers and babies were up against during the Jim Crow era of racial segregation, when the healthcare system was very much separate and unequal. And we can understand more deeply the way these structures impacted families, parents, communities when we look to the life of Mary Church Terrell. The daughter of former slaves, Terrell earned her bachelor's and master's degrees from Oberlin College and went on to become a leading activist of her time. She was a teacher, a journalist, an organizer, deeply committed to fighting all forms of racial and gender discrimination. She helped establish the National Association of Colored Women. She was a founding member of the NAACP. And through her public writings and speeches, she fiercely advocated for Black women's rights, even drawing on her own experiences to describe the difficulties that they faced. In the 1890s, she and her husband, Robert Terrell, who worked as a judge, were living relatively comfortably in Washington, D.C. They were a distinguished family, they were part of the Black elite, and they were trying to start a family. It was a long and painful journey. And in her 1940 memoir titled A Colored Woman in a White World, Terrell described the multiple hurdles she encountered in trying to have a healthy pregnancy and birth. She wrote, "The summer after my marriage, I was desperately ill and my life was despaired of. In 5 years, we lost 3 babies, one after another, shortly after birth. When my 3rd baby died 2 days after birth, I literally sank down into the very depths of despair. For months, I could not divert my thoughts from the tragedy, however hard I tried." And a few lines later, she included this reflection, noting, "Right after its birth, the baby had been placed in an improvised incubator, and I was tormented by the thought that if a genuine article had been used, its little life might have been spared. I could not help feeling that some of the methods employed in caring for my baby had caused its untimely end." Now, when I first read Terrell's memoir, how she describes this devastating period of her life, I was struck by both what she shared and what she left unsaid. the language that Terrell used to describe her feelings of loss, these cycles of pregnancy, birth, and infant death, her commentary on the kind of healthcare she had access to in her time. And I wanted to know more about this experience. And that sent me deep into the archives to Oberlin, to the Library of Congress, where Terrell's personal diaries, a whole host of family letters, and early drafts of her memoir are preserved and kept. And in looking through these stories, an even more tragic story emerges. We learn that the first time she was pregnant, Terrell suffered from Bright's disease, what today would likely be diagnosed as nephritis, and that the condition caused severe vomiting and weakness and diarrhea. In the eighth month of her pregnancy, she had a stillbirth, and that loss caused tremendous grief. And at the same time, Terrell considered it miraculous that she survived. She poured herself into her work, traveling, giving speeches, and 3 years later, she was thrilled to discover she was pregnant again. This time, she took nothing for granted. She put herself on a strict diet, she cut out meat, she vigilantly watched her health, hoping that she could avoid another tragic end. But that was not to be the case, and her second pregnancy also ended in a stillbirth. By this point, a strong network of Terrell's friends and families had stepped forward, providing multiple levels of support, sending her well wishes, her father rushing from Memphis to her home in DC to be by her side, her mother taking Mary Terrell from DC to Saratoga Springs, hoping that a more peaceful therapeutic setting will help her rest and recover. And during Terrell's third pregnancy, she and her husband decided to enlist the help of not one, but two physicians to be present when she went into labor. She gave birth to a son, but complications arose, and he died 2 days later while still in the hospital. While we know few other details, it's clear from her memoir that she was distraught over the fact that because of her race, she couldn't get care in a hospital equipped with the most sophisticated incubator model of the time, a model that could have saved her newborn's life. So by the time Terrell was pregnant for the fourth time, at this point she's 35 years old, she chose to leave Washington, D.C. She travels in her third trimester to Philadelphia, where she believes she had a better chance of receiving high-quality care from the city's network of Black doctors and nurses, including those who are affiliated with the local Black hospital, Frederick Douglass Memorial. And it was there that she gave birth to a healthy girl named Phyllis in 1901. Relieved, overjoyed, the Terrells welcomed the new addition to their family. Yet they still held the emotional scars of the earlier losses they had endured. It wasn't until Phyllis was 2 weeks old that they felt ready to announce their daughter's arrival and share the news with close family. Now, by the turn of the 20th century, right when Mary Terrell was struggling to become a mother, struggling to have an infant, her son or daughter survive, there was a growing sense, both among the public and health professionals, that the death of an infant was not inevitable, that it was not something individual families like the Terrells had to suffer through. Rather, infant mortality was increasingly seen as a national problem and something that could be prevented. Doctors and public health officials drew on the laboratory experiments of Louis Pasteur, of Robert Koch, and others that demonstrated a germ theory of disease, and used those findings to teach the public about the importance of adopting sanitary and hygienic measures to avoid getting sick from germs. And as a result of this campaign carried out by public health officers and also savvy advertisers, Americans began to incorporate new routines in their life. Practices like washing their hands with store-bought soap, using new appliances like the vacuum cleaner, even wearing masks during the flu pandemic of 1918. And these were life-saving measures because it wouldn't be until the late 1920s that we get the discovery of penicillin, followed by other antibiotics. So these non-pharmaceutical interventions developed in the 1900s and the 1910s were some of the most effective tools that individuals and communities had to stop the spread of contagious diseases. A central message that appeared throughout this public campaign was the refrain to save the babies, reflecting a belief that infant mortality could be greatly reduced if parents, especially mothers, would adopt modern infant care methods, such as giving newborns milk that had been pasteurized and placing screens in windows to prevent disease-carrying flies from entering into homes. And this infant mortality campaign received serious political backing when President Woodrow Wilson declared 1918 to be, quote, the children's year. And this kicked off a year-long campaign of public health policies and programs and initiatives. And the slogan of this nationwide effort was, quote, save 100,000 babies. This was a target, a numerical target, that came from estimates that at least half of child deaths that occurred each year could have been prevented. Now, the response to these efforts were tremendous. More than 11 million women and children attended special lectures, attended well baby and prenatal clinics, received free healthcare pamphlets that the government distributed. Yet even as health officials organized a sweeping campaign that held up a humanitarian goal of saving all infant lives, not all babies were viewed as worth saving or even worth being born. Popular eugenic and racial science theories of the day promoted the idea that Black people suffered from higher rates of disease and premature death because they were biologically inferior to white races. And within this line of thinking, people of African descent, other marginalized groups, including those with disabilities, were viewed as having unfit genes that should not be passed down. And so high infant mortality rates among this group was considered part of a process of natural selection. These racist ableist beliefs that certain groups of people should be prevented from having children, of course, has devastating consequences. The practice of involuntary sterilization is just one example, and one that continues to haunt us today. It meant that for Black families trying to participate in this 1918 campaign around the Children's Year, they faced multiple barriers in their efforts to protect their children's health. On the one hand, practices of Jim Crow segregation restricted Black families' access to infant welfare programs, into the actual facilities, the clinics, the spaces, even the professionals who were dispensing the kind of advice and resources and services they desperately needed. And on the other hand, a healthcare profession that largely regarded the state of poor health among Black Americans, among Black babies, as something that was fixed, as something that was racially determined and impervious to intervention. This really undermined efforts to improve infant welfare for all. And it meant that even as Black and white infant deaths decreased as they went down, they remained apart. So how did Black communities respond? For Black activists, social reformers living in the early decades of the 20th century, they pursued several strategies to combat the discrimination they faced and to demonstrate that the higher rates of infant death in their communities reflected social, environmental, economic inequalities, and were not rooted in inherent biological differences. And these efforts drew support from all corners of Black life. It engaged the participation of churches, of political leaders, journalists, and of course, health practitioners. A central component involved the creation of community-serving institutions and programs, and Black women led many of these initiatives. They tapped into their religious and social networks to distribute pamphlets on prenatal care. They organized health clubs for mothers, for expectant mothers, even hosting screenings of educational films. They utilized a real range of educational tools and strategies that was intentional and designed to help them reach individuals across literacy levels. The archives of Black neighborhood organizations are really filled with these examples of events that are hosted in centrally located spaces like schools and churches and neighborhood centers. So when we look, for example, to the image on your left, we see a group of Black mothers and infants standing outside of a community center in Detroit. The local chapter of the National Urban League, a leading Black civic organization, sponsored these well baby clinics in Michigan and other states that gave mothers an opportunity to have their babies checked by doctors, a team of Black doctors, nurses, and even dentists. And the image on the right is of a similar clinic, this one held in a church in Savannah, Georgia. At these well baby clinics, healthcare professionals measured children's growth and development. They checked for signs of malnutrition. They offered guidance if there were any worrying signs that a baby was sick. And getting this kind of clinical evaluation for free for your child was extremely valuable to families who might not otherwise be able to afford medical care. Parents got practical advice about the signs to watch out for as their children grew. And these are the kinds of checkups that will later evolve into the routine child visits that are now an integral part of pediatrics practice. On this side, we see another example of the kind of grassroots work done in Black communities to improve infant welfare. This was a little known initiative, but one that was very popular at the time, of organizing clubs for little mothers. These were young girls who attended weekly classes taught by healthcare workers, where they learned the importance of personal hygiene, also how to prepare baby's milk in a bottle, ways to keep a home clean. All of these lessons were intended to educate girls on how to help take care of their younger siblings, especially if their parents worked outside of the home. These were popular across different racial and ethnic groups, but in a period when nearly a third, 33% of married Black women worked outside of the home, compared to 6% of married white women. This idea of educating Black girls and girls who were most likely put in charge of watching over their siblings while their parents worked was really seen as important, seen as quite valuable. So pictured on the right are a group of young girls gathered at one of these sessions in Philadelphia, and on the left is a feature from the NAACP's nationally circulating magazine called The Crisis, describing the activities of a Little Mothers Club in the Black Cincinnati suburb of Walnut Hills. Now, alongside these community-based efforts to improve health knowledge and healthcare resources, some of the leading Black figures, intellectuals, social scientists of the time, like W.E.B. Du Bois, were also working to roundly challenge these theories of biological racism, of inherent susceptibility to disease and premature death. And he was among others who undertook painstaking empirical research to demonstrate the effects of social, of political, and economic forces on Black mortality, especially among young children. And this was a topic that was close to home for Du Bois. In 1899, his firstborn son, Burghardt, pictured here, came down sick with fever. And for days, Du Bois and his wife, Nina, tried to find a doctor willing to treat their son. When Burghardt died, it struck a great blow to the parents, a painful period that Du Bois wrote about in his acclaimed work, The Souls of Black Folk. And at this point in his career, Du Bois had conducted an exhaustive study of the social conditions of African Americans living in Philadelphia, in which he went canvassing door to door, talking to families, interviewing them about their lives, combining the data he collected in these surveys with careful statistical analyses. And the data he gathered detailed how practices of racial discrimination, housing discrimination, forced Black Philadelphians to live in the most unsafe, unsanitary, and unhealthy parts of the city. And in marshaling all this evidence, Du Bois argued for the importance of understanding man-made factors, social factors, and how they shape and impact health outcomes, what today we would refer to as the social and political determinants of health. He followed up this 1896 study with another published in 1906 under the title The Health and Physique of the Negro American. For this, Du Bois again drew on multiple sources of data, including census reports, hospital statistics, even looking through mortality information that institutions like life insurance companies had on file, using all of it to really present a diverse portrait of Black health across the country and across social and economic strata. And here again, Du Bois sought to challenge and refute arguments that Black people were inherently more susceptible to disease and premature death. As he stated plainly, the high infantile mortality of Philadelphia today is not a Negro affair, but an index of a social condition. Much of what Du Bois highlighted and called for in these studies remains relevant in contemporary research on racial health disparities, especially his critique against claims of so-called racial characteristics that can be generalized across groups, his close attention to documenting diversity and difference within Black communities, and the ways in which he demonstrated that health disparities were inextricably linked to other forms of inequality. So in reflecting on this early 20th century moment, we've seen the unique challenges Black families have faced in trying to safeguard their infants from sickness and death, how they've marshaled empirical studies and emotional appeals to describe in damning detail the American roots of this health disparity. Some chose to draw on their experiences of loss to help others avoid a similar fate. Through educating their communities in preventative measures, organizing needed healthcare resources, or simply sharing their stories to create a space for others to do the same, Black parents, professionals, and reformers have chosen not to remain silent, but to speak out about the unjust life chances that they and their children face. In our current moment, when there's growing attention to the high rates of Black maternal and infant death, it's important to recognize that Black communities have long worked to raise awareness of this issue. They have drawn attention to the ways in which they bear a heavier burden of sickness and morbidity and mortality that for too long has been rationalized as natural, as inevitable, or as the fault of individuals, rather than a tragic reflection of an unequal and inequitable healthcare system. They've left behind a rich legacy of community-based work, reflecting a deep commitment to health and racial justice that we cannot afford to overlook if we stand any chance of overcoming this inequality. Thank you. So now we have time for some questions, right? Okay, I'm looking at Nicole. So we have wonderful opportunity to have people in the room as well as I know folks attending via Zoom. So hopefully we'll be able to pull questions from both dimensions, virtual and physical.
Dr. Muigai, we do have a question or actually a comment online. One individual just wanted to say thank you for this wonderful presentation. And Dr. Joy Howell on your CDC slide says that the disparity, however, has increased, I believe, regarding the ratio of Black infant death to white infant death.
I'm sorry, so could you repeat the part of the question?
I think it's more of a comment.
Mhm.
Dr. Joy Howell, she said the disparity, however, has increased, I believe, regarding the ratio of Black infant death to white infant death.
Right, no, so that is, thank you for that comment, for attending and for noting that recent trend. It is true when we look to the graph that there have been some moments of small convergences, and especially in the past 40 years, really since the 1980s, we start to see a widening of this gap between Black and infant survival. And that is, I think a real reason why there has been, particularly in the past few years, more growing attention to this, of framing around it as something that is a crisis, something that garners kind of real urgent attention. But that longer view does show, I would argue, a real kind of troubling stability in the fact that these are disparities that have really been in place since as long as government officials, public health officials have considered it important to pay attention to the deaths of a very young, very small group of individuals. And so that means, looking to what are the deeper and older causes of this? This isn't something that's emerging because of newer technologies or sort of newer interventions. Those might be contributing factors, but there are real structural and systemic reasons that have always been driving these rates and keeping them apart when we look sort of across the 20th century. So that is, both parts of that picture are really worth keeping in mind.
We have another question from online, or do we have one in person? So go ahead, Michele.
So the African American people mortality is still like 2.5% higher than white American, even Asian. What do you think when you think back in the history? What do you think that things that implement the post production, like meaning that better or in changing? I don't think that it's much more social, like Facebook or lack of sunlight stuff like that. Behind. What do you think? What can be done?
Sure. Okay. So the question coming from the corner of the room was sort of a call to think about what are the most important things that can be changed to address why the rates among Black Americans are higher than other racial and ethnic groups. And when we look to the past and continuing in present day efforts, we see there's attention to things like prenatal care. There's concerns about social and environmental conditions and circumstances. There's questions about what actually happens when Black pregnant women, mothers, newborns are in hospital settings or other settings. Is there something that's going wrong? Is there something that can be addressed? And what I would say to all of that is that it is all of that. It's really, it can't, there isn't a magic bullet solution to fixing this issue. I think that any time when we look to the past and we see either health officials or reformers or others focusing on just one aspect of this, that might be addressed, but it never has done away with these disparate and unequal outcomes. And so the tendency to think that it might be, the need for a technological intervention, something like the NICU or an incubator. It might be, if we could just treat respiratory distress syndrome better, then maybe these disparities will go away. That only takes us so far. And even with those inventions and those developments, it's also looking to see, to the ways in which they are made accessible, truly accessible to all, thinking across region, across sort of economic resources, across accessibility, and for families and parents who are entering into these healthcare systems, who are in need of critical care, what actually happens in those spaces. So here, sharing these stories of mothers describing their guilt, the grief, the remorse they have in terms of what happens to them, to what extent was that something that was acknowledged or acted upon by healthcare providers or those around them. So I think that it really does require thinking about it much more holistically and comprehensively than to, as alluring as it might be, to simply think that it is just one thing that's missing or one thing that we need to draw our attention to. And I think that's one of the reasons why it has been such an enduring, really one of the most enduring health disparities that we see in this country. Yes.
Yeah. Thank you so much for your talk. It was incredible and thought-provoking. Your last comment, though, makes me think about the fact that right now, given the maternal mortality rate that is ever climbing, despite many interventions, one of the interventions that is getting a lot of press and attention is the Black doulas, which you just mentioned. And I think one of my fears is that the focus will be on the Black doulas changing maternal mortality. And as you just said, it's going to take more than Black doulas because eventually people need to go home. They need to go back into their communities where they're not getting education and all of the other, socio-political disparities that exist. What are your thoughts on that?
Thank you. That is a great question. And I also share similar questions to the ones that you raised about the ways in which the work and profile of Black doulas, who are often way underpaid and underappreciated and valued when they are brought into healthcare systems and hospital settings and really trying to advocate and support Black women. I think it's also important for us to put that work and Black women's birthing work and contributions in that historical context too, because here, when we see a tendency or an interest in holding up Black doulas as a potential solution to these disparities, to these outcomes that Black mothers are facing and up against, we should not forget that just a few decades before, Black midwives were the ones blamed for these issues, and that there was a real concerted effort, a real campaign amongst federal health officials, doctors, and nurses to push Black midwives out of practice, to make the practice of lay midwifery illegal, to prevent them from providing the comprehensive, the holistic, and the effective care that Black families had long relied on and trusted. So that is the other side to this coin, and is really important for thinking about, it's not just that there's much more to the ways in which Black women's labor contributions and the ways in which they're both held to blame and seen as responsible for the situation that I think speaks to the question and to the point that you're raising. So thank you for that. Yes.
So kind of related to Laura's question, I think one of the things I thought of was when you were telling the story of Mary Church Terrell and her lack of access to an appropriate incubator was seen as part of the problem. And I think we have a tendency nowadays to say, well, a lot of this gap, especially in maternal mortality, which I know more about than infant mortality, is because Black women are delivering at hospitals that don't have access to the right equipment or access to the best doctors, right? And I think it's very easy for us to comfort ourselves by saying that. And it doesn't get at the problem that, yes, there are higher rates of death in those hospitals, but even at hospitals that are well-resourced, Black women aren't getting the same treatment as white women. And what I think a lot of us who work in this field struggle with is, how do we change that, right? We can bring in doula programs and we can try to improve things in hospitals and lower resource settings, but how do we improve the workforce of the people who are not treating Black women the same way as they're treating white women? So ideas from history?
Would you mind? Okay, no, I can work with that. So that's a great set of comments that you bring up, thinking about the changing regionalization and geographic accessibility, because there's also been obstetrical deserts, closures of hospitals that make access, especially in critical situations, all the more significant in these moments. And so that's important too. And that has always been part of the story, because even as the healthcare system really develops and modernizes and explodes in the middle decades of the 20th century, it remains segregated, but it also remains heavily concentrated in areas away from where poor Black rural families are. And so that, thinking about, we can think about access on so many levels, but just when it's a matter of seconds or minutes, and the kind of care that is available, that has the equipment, but also the staff and the staff and the systems in place to deal with families across needs, those who have had prenatal care from the earliest moments in a first trimester to those who have had complications arise in the third trimester, that this kind of dexterity and flexibility and willingness, again, to not necessarily place the blame on laboring mothers for coming too late, for seeking care in the wrong places, for turning to the wrong people, is definitely a dynamic that requires addressing. And I think one that can also be, integrated when it comes to simply how healthcare professionals are trained. I think that's really important, that to sort of focus on what happens in the office in these clinical encounters is too late, and to really kind of bring that much more broader, holistic, but also socially rooted understanding can really equip the kind of care that is delivered, that is dispensed, that is provided for families across need. So yeah, thank you for raising those points. Yes, Nicole.
So we have a somewhat related question online from Jeremy Caplet. He said, "Hi, Dr. Muigai, thank you so much for your presentation. Given how gut-wrenching much of these stories were to hear, it is unimaginable the suffering they were to bear. In light of that reality, what can providers hoping to care for children in the future do to attempt to earn back trust from justifiably concerned patients?"
That's a very good question. And I think that part of what I think is important in terms of bringing in these kinds of stories, which are very heartbreaking and really can be hard to sit with at times is it really underscores the importance of listening to Black women, to mothers, to families when they detail what they've been through, what they're going through, what they fear if they are committed or interested in having a family, in birthing a child, in raising children, that particular clinical encounter or interaction is part of a much larger life story. And these are the kinds of perspectives and testimonies that come through sometimes when we're lucky and we find them in the archives. And I think that, physicians have, that kind of ear, are trained to have the kind of ear to listen, to take a patient's history. And that is beyond, kind of a history of diagnoses and symptoms and clinical conditions, but to really think much more broadly about, what does it mean to have that kind of conversation, to listen to a person in those moments. And I think that that is something that we can look to history, but we can also think about present day encounters and interactions for those who are committed to doing that kind of work. Yes.
Thank you so much for your talk. Yeah, it was a great talk. Are there any parts of the country where those lines have become inverted? Can we look to anywhere else in the United States where those lines have inverted? I'm just curious. Yeah, where Black infant mortality has gone lower or met white infant mortality, and can they be used as a model, or is there something to be learned from those areas? I don't know.
Mm-hmm. That's a very good question. I think that if there were, and if they were stable, enduring in any sort of way, we would probably know about that, because that would be very, very big news. The news is quite the opposite, and continues to be. It really is a story that moves in the other direction. And so, as much as we might want to look for a case like that, it might be more interesting to think beyond the US, not to just think sort of, are there particular cities or particular counties, but what's going on here? Because infant mortality and child mortality, it's a major issue across the world and has been. And there have been dramatic, the trend that I showed at the beginning is something that you can map in a lot of other places around the world. So that story of a decline, a real epidemiological shift, is not one that's unique to this country, but this, enduring inequity of survival is something that is particular. And I think that is, worth maybe looking to other countries just in terms of the delivery of care, in terms of, again, sort of the practitioners and ways of training and offering and providing care for laboring women, for birthing women, for mothers, for newborns, especially in the first few weeks of life, first few months of life, that might be something that's potentially fruitful and interesting. And I know a lot of people do think about that in that kind of international context as well.
Thank you.
Yes.
I also wonder if we go outside of the scope of the United States and we add in another variable, because we always love to do that. But if we add in the fact that the United States has like the worst parental leave ever, really, everywhere, compared to everywhere else. I wonder, because infancy isn't just, the first day of life and they died as like a neonate, but it goes on beyond that for months. And there are places in the world where, oh my God, sorry. There are places in the world where taking 6 months of paid leave is considered short, to spend time with your new family. So I wonder if that has any impact as well.
I think thinking about how the ways in which policies can better address this or speak to this is important. And that's a great example of how we can hold issues of maternal and infant mortality as distinct, or want to hold them as distinct. But when it comes to something like parental leave, and providing or supporting for more time for rest, recovery, for bonding for both mother and baby, or caregiver and newborn, those dynamics, those conditions, those realities are very much interrelated. So stronger policies in that front would be supporting would be really addressing more than one health issue, more than one health need. So I think you are right to say that there is room and space to think about how health policies and public policies could address this on a much more structural and systemic level.
We've had more than 100 guests join us online, so we're unfortunately not going to get to all the questions that are being asked online, but we will sneak in one more final question from our online audience, and that's from Sheila Maru, who said, "Thank you for this wonderful talk. I was wondering if you found any evidence for traditional practices by Black midwives or Black birth support workers in the Jim Crow era and prior that had a positive impact on Black infant survival."
Yeah, that's a great question. And I have spent a lot of time thinking about and researching the role of Black midwives. They were the main providers of maternal and infant care through the middle decades of the 20th century. So, the kind of the attendants in which an infant spent its first moments. One of the things that you see when you look to the historical records, the testimonies and interviews and oral histories that Black lay midwives left behind and participated in, is that model of care was very different than thinking about the birth as an event, as a birth as something that you attend and can measure in a matter of minutes or hours. The work that midwives were doing engaged pregnant women weeks before to weeks after. And so they were supporting mothers in the postpartum period, supporting their families, visiting routinely, checking on newborns to make sure the cord dropped off, it healed properly. That was a major concern, especially through the 1950s, because neonatal tetanus was a devastating and a very, very fatal disease that was particularly impacted newborns before the umbilical cord had properly healed. Midwives were very attuned to the kind of care and attention that happens before and after. So there is a real reason, there's a lot of reasons behind why Black families relied and turned to midwives, because of that holistic model, because of the comprehensive care, because of sort of the natural-based approach to supporting, not just delivering a baby in a particular moment.
Thank you so much, Dr. Muigai, for this incredible presentation tonight. You've given us all a lot to think about. Thank you to everyone who joined us in person. It's so nice to see faces, as Pauline said again. And thank you to everyone who joined us online. We hope you will all join us again on March 2nd for our next Heberden Society lecture. And have a good evening.
Thank you.